Good afternoon, everyone, and welcome to today's session. Session number 6, COVID-19 Best Practices in Nursing Homes. I am Susan Ryan, the Senior Director for the Greenhouse Project, and we are so excited to be partnering with Project ECHO in this incredible initiative, and to really utilize the Project ECHO model, which really leverages technology to be able to identify and share best practices among ourselves, and then to really be able to kind of tap into case-based learning and really understand what's really happening out there so that we're able to improve and monitor our outcomes so we get better. So thank you so much for attending today's session, and that is preparing for the possible, or shall I say maybe probable, Twindemic, and that is the convergence of the flu season along with COVID-19. And I'm excited that Dr. Al Power will share a didactic presentation in just a few minutes. And Jennifer DeSalvo and Bob Wesley from St. John's Home in Rochester, New York will be sharing a case scenario. And then we will have some polls and announcements at the end. So thank you so much for joining today. And I'll turn it to Janet to just go over some housekeeping announcements as we get started.
Okay, hello. You will be in listen-only mode today, just so you know, but we do encourage you to use your webcam so that we can get to know you a little bit better. The chat window down at the bottom of your screen is available for you to use for any IT technical issues that you have. As well, we ask you to please put your name and the name of your organization in the chat for everybody to see who's on the meeting. And then later we'll be using that when we have the question and answer session. The session will be recorded today. It is being recorded, just so you know. So we will be sending out, I will be sending out that recording to you either later today or by tomorrow. Thank you.
Thanks, Janet. And my colleague Marla is joining me today. Marla, would you mind saying hello to everyone?
Hi everyone, Marla DeVries, Director of Resource Development with the Greenhouse Project. I will pop back in a little bit later to facilitate some Q&A, and so I encourage you to use the chat box anytime throughout the case presentation or Al's presentation.
Thank you, Marla. And Janet has already launched our first poll, or she's launching it, I should say, but she has shown you the map. And we always like to know where you are calling in from. So take just a few minutes to identify which part of the country you're calling in from. I'm always excited to see that there are people actually outside the US that join us. So welcome to all of you. All right, Janet, you can close it. And once again, the Northeast at 31%. That's followed by the Southeast at 23%. 17% are from the Southwest, 14% from the Midwest, 9% from the Pacific area, and 3% from Rocky Mountain, and another 3% from outside the US. So thank you, welcome to all of you that are here. And I'm always excited and really grateful for our subject matter experts that join us and really share their expertise. And so today, Eric Riguera, I'd love for you to introduce yourself to our group today.
Sure.
Eric?
Good afternoon, everyone. My name is Eric Riguera. Thanks for having me again. I'm the Director of Nursing of the Jewish Home Family here in Bergen County, New Jersey. Thank you.
Thank you, Eric. And Eric is he's doing double time today as he's teaching a class with his group at Jewish Home Family. So Eric, really grateful you took some time to join us once again.
Thanks.
Jen DeSalvo from St. John's, I'd love for you to introduce yourself and then your colleague, Bob. Jen, you're on mute, or maybe you're getting yourself unmuted. There you go.
Hi, I'm Jen DeSalvo. I'm the Director of Nursing at Penfield Greenhouses, part of St. John's Family. I'm here today with Bob Weasley, who is the infection preventionist at our main campus.
Awesome. Thank you, Jen. And Bob?
Bob Wesley, Nurse Operations Specialist, Infection Preventionist here at St. John's Home, Rochester, New York. Glad to be joining Jen in this discussion. Thank you.
Yeah, thanks so much for being here. And last but not least, Dr. Al Power, introduce yourself, and then I'm going to invite you just to share your screen and your presentation.
Okay, thanks. Hi, everybody. Alan Power, geriatrician and educator from Rochester, New York. And I used to work at St. John's Home. I'm so pleased to be sharing this with Bob and Jen. Not only helped plan the Penfield Greenhouse Home several years ago, but I just had the pleasure and privilege of helping my mother to move in to the Penfield Greenhouse Homes last week. And it's been already a wonderful experience, not only the care, the attention. It truly is a place, as Greenhouse often said, where love matters. I saw it as a provider and I see it as a family member. But maybe the best thing I'll say to begin with that you don't often hear about. The greenhouses opened 8.5 years ago. And when I walked in the door, and I was there twice on 2 shifts the first day, and the majority of faces I saw greeting me were people who were there when they opened 8.5 years ago. And to me, that's a really powerful thing when you see the people who have truly made this their calling. And so I appreciate that. I'm going to make a few comments about coronavirus. I'm really anxious to hear what Bob has to say, and feel free to second or disagree with anything I say. How do I share? Do I share the screen? Yeah, okay, good. It says one at a time. I'm not, Janet, I'm not seeing that I can make this happen. Although Zoom to share your screen, okay. Okay, I'm letting that happen. Nope, don't want to do that. I almost left the meeting.
Don't leave us.
Now I got a poll coming up. Hang on. Share screen. Okay, found it. All right, well, there goes half my didactic right there. There we go. Okay, so let me get to the slideshow for everybody. Oh, my controls are overlying that.
There you go.
All right, I found it. Thanks, everybody. So moving forward into the next seasons, winter is coming, as they say. I just would like to very quickly give my assessment of where I think things stand, particularly here in the US, what I think is coming, and what I think are practical things that we can do about it. I'm going to kind of rush through these, but happy to answer your questions. I want to make sure we have plenty of time for the folks at St. John's to add their part. So a couple of quotes, and I had forgotten that I wrote these. They were in Dementia Beyond Disease, and in the last chapter, which I co-wrote with Daniela Greenwood from Australia, there were a couple of quotes that someone on social media pointed out we had written, actually back in 2013, 7 years ago. The first one, as it stands now, the number of people living with dementia is expected to nearly triple by 2050. While I expect that we may discover new drug therapies to slow the progression of the illness, I do not expect the total number of people living with these conditions will be dramatically less than predicted. That would only happen if an effective prevention or cure were developed, or if some other unexpected illness or event wiped out a large proportion of the older adult population. Of course, nobody expected that we would see this excess deaths of elders around the world, but it has happened. Probably the more telling quote, however, was this one later in the chapter. Change is already happening, and it's up to us to craft the direction of these changes. If we do not begin to move toward the new inclusive society described throughout this chapter, the answers will be forced upon us in a more drastic, perhaps even violent way, as our changing population overwhelms our inadequate approaches to aging and dementia. And maybe one of the most brilliant things I've heard about what's happened here with COVID came at the Pioneer Network from my friend, Dr. Emmy Kyoda. And what Emmy said was, COVID did not cause a disaster. COVID is just a virus that is part of nature. What caused the disaster was our inadequate preparation and response, as well as our faulty infrastructure. So here's where we are. What can we do? Let me give you what I consider to be a non-political view of coronavirus. First of all, COVID-19 is a virus. It is not some foreign enemy at war with us, even though we like to treat it that way. So as a virus, COVID doesn't really care what political party you belong to. It doesn't care if you live in a red or a blue state. It doesn't read the calendar, and it's not going to stop just because 2020 is finally over with. COVID doesn't care what you think about the CDC, the WHO, Anthony Fauci, or the MyPillow guy. That no matter who you are, if you expose yourself to COVID, there's a definite chance that it will infect you. Some more COVID facts. It's spread by contact, droplets, and it appears to be airborne as well. It is, I should say, far more contagious and far more deadly than influenza, I think is what we're finding out. The mortality risk increases with age and with any coexisting medical conditions. And keep in mind that one coexisting condition could be respiratory compromise, which could be caused by a recent case of influenza. Remember, the majority of cases during the flu pandemic from 1918 were not from the flu directly, but from the associated bacterial pneumonias that happened when compromised people got the flu and then were exposed to super infections. And the other big thing about COVID is it is not just a respiratory illness, it's a multi-system illness. It affects the heart, it affects the brain, it affects the kidneys, the liver, the skin. And it causes disability, not just death. And even though a person over 65 has a 20-fold increased risk of death compared to a younger person, keep in mind, it was recently reported that a 30-year-old actually has a greater chance of long-term illness and disability than the 60-year-old has of dying from it. So don't think because you're young that just surviving COVID leaves you unscathed. I know people who are still struggling, who are younger and were healthy months after their infection. Demographics as of 9/20, over 30 million cases worldwide, nearly 1 million deaths worldwide. US over 6.7 million cases. And we now, as you know, have crossed over 200,000 deaths. We know that at least 40% of US deaths have occurred in long-term care in the US. Because of the way deaths are reported, it may be higher. We don't know that for sure. And the Washington Post reported last week that over 13,000 excess deaths so far this year due to coronavirus, either the infection and or the effects of isolation that have affected people negatively with dementia. And the US has not flattened the curve. We managed to have a stably increasing curve. So we're averaging about 1,000 US deaths every day. And once again, I just looked at the new statistics as of today. In the past 7 days, there have been over 300,000 new cases in the US. And once again, about 1,000 deaths per day. So the current situation, once again, these are facts. These are not politics. There has been no standardized response across states. We still see widely varying behaviors in different aspects of different states. Many US citizens are not following the medical guidelines. Several vaccine trials are underway, but nothing is ready for release. Antiviral drug therapies give modest benefit, and just the latest JAMA reported the remdesivir study that was just done showed that really it was very underwhelming. Not much of anything happened for people. And CMS has just directed all long-term care homes to resume visitation via their guidelines, and there could be consequences if we don't do that. So these are my predictions. I don't believe there will be a widely available COVID vaccine before 2021 at the earliest. I don't see any evidence that there will be significant changes in national policy or personal behavior over the next 3 months. I think as a result, we will be lucky to get through the winter with fewer than a total of 350 to 400,000 deaths. And the older people and people living with dementia will still be disproportionately affected. So what can we do about this? Well, I think that working in long-term care, there is still plenty that we can do. So these are my suggestions. Step 1, infection prevention. Number 1, 2, and 3 on the list, get your flu shots. Don't make yourself susceptible to super infection, double infection. Stay healthy. Flu shots have an evidence base. And even though they may not be 100% effective, they can make the case milder. They can help with herd immunity without killing people, which is what herd immunity requires if we want to get it from COVID. So get your flu shots. Continue hand washing, distancing, all those medical infection control guidelines. Those are not going to change. Review med lists. Is everything necessary? This is a good time to look at the meds our elders are on, because polypharmacy is always dangerous. It can be even more dangerous during a coronavirus infection. Unnecessary antipsychotics and other sedating drugs when you are febrile, delirious, lethargic is not necessarily a good thing. Unnecessary diuretics if dehydration is an issue, or things that affect your appetite. And one of the biggest things we have to be concerned about is the PPI, the proton pump inhibitors. This appears to be an area of risk. These are drugs like Prilosec, Nexium, Prevacid. Those are some of the brand names. You can get them over the counter. A lot of people in long-term care are taking these drugs. And what seems to happen is when people go to the emergency room, When people end up in the hospital, and I'm sure Bob will speak to when people end up in the intensive care unit, a lot of people just get put on these as preventive medicine. And what happens is they move out to long-term care and it never gets stopped, even though the risk may not be there. These drugs affect the acid content of the stomach, which may be a barrier to infection. And therefore, they do seem to increase the risk of illness and death from COVID. So if you need it, great. If you don't, try Pepcid or Zantac or nothing at all. Cohort care staff in long-term care, assisted living, and home community-based services. I think CMS is inadequate here. They talk a lot about cohorting residents, and I might challenge that. I'm going to do that in the podcast tomorrow. I guess in spite of me following the science, I haven't been convinced that moving residents around is the answer, because Greenhouse has done so well with COVID, and I don't see them moving lots of people around in most of their households. But the real danger of spreading infection to me, people with dementia aside who are not distancing, I think the vast majority is care staff spreading it from person to person. And when we have people floating from one neighborhood to another, from one house to another, from one company to another, as we often do, I think that is where a much more significant danger lies. And limit that cross-visitation. A study showed that there has been excess death of probably thousands of nursing home residents in the US because of doctors, therapists, other professionals going to more than one building. And they followed people's cell phones to find out who was going where and tried to estimate the number of unnecessary infections from people covering separate different places. And that also has to do with people who cannot fill a full-time job in one place and have to work at 2 or 3 different companies. Step 2, maintain engagement and well-being. I don't disagree with the idea that we need visitation. I'll talk about that in just a moment. I believe that the best answers to infection control, as Jennifer and I said on the podcast that was just released today, are in close continuous relationships. And as far as supporting people, find out what is meaningful for each person and creatively address those needs, and understand people's individual rhythms so that you can follow their rhythms and not enforce black and white generic approaches on people, because that never works. Use science to guide engagement. We can actually increase engagement and still follow the science. These are not mutually exclusive. Keep people moving indoors and outdoors as safely as possible, and there are ways to do that. There are ways to touch safely. I found that right at St. John's Greenhouse Homes. And I'll tell you once again, something about COVID being a virus. COVID doesn't know whether it's sitting on the hand of a family member or a staff member. If a staff member can have appropriate screening and testing and education, put on the appropriate equipment and touch an elder, then theoretically a family member should be able to do that as well. They are not automatically more infectious. If anything, a family member might be overall less likely to be contagious than someone who's working all the time in the healthcare environment. And negotiate upside and downside risk. We'll talk more about that. Step 3, I heard a wonderful call this week from Global Aging Network from Steve Cornelison, who's the CEO of Mercy Health in Australia. During this pandemic, in spite of the problems in Victoria, they have had no restriction of visitation during the pandemic, but they have done some things. They have made sure all visitors have training, both online and on-site training. They've had to demonstrate competency with infection control precautions. They are screened the same way the staff are screened. They've added external areas where visits can occur. They've spaced out visits and done other things. So it can be done, but once again, follow the science and be reasonable. And it may not be equal for everybody. Remember, fair and equal are not the same thing. If you have a 10-year-old and an 18-year-old, equal would say they can do the same thing on a Saturday night, but that doesn't necessarily make sense. So some family members may be more essential visitors than others, and you may have to stage things at the beginning until you're able to get a handle on this. Don't be afraid to customize your policy. Don't think that black and white is going to work. How about that dementia conundrum? How about those people that can't remember these precautions? First of all, consistent staffing is the only key. Work on understanding well-being and meaningful engagement. Remember that frequent reorientation and redirection do not work. It's like the person that constantly goes over to the chair and says, sit down, sit down, sit down, without trying to understand why the person is getting up. It doesn't change anything, particularly in people who are forgetful. Help people to keep moving. Give them cues for safer practices. Use one-on-one for walking or going outside, or use 1 on 2 or 3 if you have a couple people that need some guidance. Do not use physical or chemical restraints for walking. I'm very disappointed, being a regular recipient of the reports, that there have been no recent reports from CMS on antipsychotic quarterly reports. Nothing since 2019. From what I've seen, chemical antipsychotics are going up because people who want to walk with dementia, people who don't know how to wash their hands or wear a mask, are being given antipsychotics. Antipsychotics do not explain to you to wear a mask, to wash your hands, or tell you where you can walk and where you can't walk. The only thing they do is sedate people, which is a dangerous thing to do with COVID and will increase people's risk of injury and death. I believe it's indefensible to use the drugs as restraints in this case. And engage family members safely. Do not just strictly isolate them. So what about everything else in between? That doesn't answer all your conflict and your debates. We're between a rock and a hard place. First of all, with each person and what they want to do, know their priorities and their own risk tolerance too. There is no protocol that meets everybody's needs. Some people like bungee jumping. That's not me. So my risk tolerance may be better, maybe higher in things like giving my opinions on webinars, but lower around things like jumping out of a plane or jumping with something attached to my feet. Avoid all or none thinking. Look for nuance. There's a spectrum of choice for people. There's a spectrum of abilities. It's not just he can do this, he can't do it. Look at upside and downside risks, which means never ask what's the risk of doing something without also asking what's the risk of not doing it. And the excess disability and death we've seen from social isolation since COVID has shown us that pure quarantine and sticking people in their rooms alone is not the safest choice. One caveat, of course, if someone is trying to make a choice that directly significantly impacts the health of those around them, then that's an area up for discussion. We don't live in a vacuum, and we can't just do anything we want. Just like we're telling people in society, your freedom to not wear a mask ends when you start making other people sick. What can we do in the long term? These are the things we have to move toward. A permanent, consistent staffing model for a lot of reasons that I've talked about many times before. That's another didactic. Private rooms, more private rooms with any new renovation, any new build, make them private for a lot of reasons. Privacy, dignity, human rights, if not infection control. Smaller households seem to be better. Greenhouse has shown us that. Central open areas that allow people to engage while distancing seem to be better than the long hallways and the crowded living areas. Full-time positions and locations for care staff. This is something Canada is working on right now as part of their national commission, which is great. They're also looking at equitable pay and benefits. They're looking at more equality for nurses and aides between acute care and long-term care so that they don't lose all their staff to acute care. We need regulatory and reimbursement reform, of course, to do these things. It's not just about providers doing things differently. And I believe there should be a national commission for long-term care. And I think it needs to be composed of multiple stakeholders who are not just committed to preserving the status quo. So that is my quick and easy didactic. Here's a wonderful picture I borrowed from Emmy Kyoto of an elder negotiating risks so that she could get something out of a cupboard. And so thanks everybody for listening to me, and I'm happy to answer any questions from either subject matter experts or anybody on the call. Thanks again.
Great, Al, that was fantastic. Thank you. And you gave us a mouthful, which is just exactly what I would expect you to do. So Eric, I'm going to ask if you've got any questions for Dr. Power, but we'll start with you.
Sure, just a couple of comments. First of all, Dr. Powers, that's a great PowerPoint and slideshow. I like the COVID facts actually, and you always hit the nail on the head. Right now, there's no standardized response, which CMS, the guidelines of the CMS guidelines, and unfortunately with the New Jersey Department of Guidelines, it's not quite similar. And the issue with this is the struggle is, there's creating some confusion. And for instance, CMS is saying, in order for you to go to the next phase, you have 14 days of zero outbreaks, which means you don't have any COVID cases. Unfortunately, in New Jersey Department of Health, it's 28 days, so it's 4 weeks. So what we're experiencing right now, it's within 28 days, it's since we're testing the elders and the staff members, which also included, we just included 2 weeks ago that were positive more than 90 days. So it's included as well. So there's a bigger chance that we will have a positive result. So that's an issue. So what we're thinking about this is, when are we going to the next phase? So now this is going to be a very long journey for us. And that's the struggle, because we are seeing right now, is as what you said, Dr. Powers, the elders are the one who's really getting affected by this, especially without social isolation. And we're really pushing ourselves and pushing the envelope. How can we make, how can we make sure that we're keeping the elders engaged? And that's the real focus right now. Because again, with these constraints of these regulations and rules, and again, I totally empathize what they're saying, what they're initiating. But again, on the other hand, how can we engage our elders? That's the big concern right now.
Yeah, and I thanks for that, Eric. And I think that, as I said, there needs to be nuance in the policies and procedures. When you say 28 days straight, that really that's a burden. If it means really locking down and keeping everybody out. And there's so many ways that people can help any kind of a long-term care or assisted living community. Volunteers and family members can do some of the work off-site, off-site of the neighborhood that takes the care staff away from bedside care. There's, with screening, there's so many ways you can be creative around this. And so I think that we need to really engage people. And I'm hoping the folks from St. John's will share with us maybe some of the things they've done to be creative around some of these black and white restrictions. Because black and white doesn't work. Doesn't work in a pandemic. It doesn't work in life. Doesn't work with people. So I appreciate what you're going through. And I wish I had an answer, but we need to get past this all or none thinking.
Right, thank you.
So Marla, I'm gonna go to you to see what questions have come in the chat.
Sure. So here's one. Are you recommending that residents receive the pneumonia vaccine as well as the flu vaccine?
If they have not had it, yes. And it appears that the new pneumonia vaccine which requires a booster, is much more effective than the old one. They've had a few generations of these. I just got the second one myself, as I'm one of those people that's, old enough. And yes, I recommend, I'm a fan of vaccines. I recommend the pneumonia vaccine, and I recommend the flu vaccine. And I think there are very few people who absolutely cannot take these. So I would suggest that people do it, because once again, more people die from secondary pneumonias than they do from, or other complications than they do from the actual flu virus infection causing their death, I believe.
Is there an ideal time to get the flu shot? So the comment says, my father's social worker tells me later, like December is better because the flu hits in January or February.
Yeah.
And I thought the sooner the
Depending
better.
on where you live. I've always waited a little bit longer myself. I've usually waited till October, even November. In Rochester, it's rare to see influenza here before Christmas. And you need about 2 weeks to build your immunity, unless you're one of those people that needs a booster, in which case you should probably start a little bit earlier so you have room for 2 shots. But I usually wait a little bit. I know some people are going before Labor Day, and I think that's too early, because we do sometimes have a late season in Rochester. We can stretch into March, even April, and I worry about it wearing off, particularly in older people. Having said that, though, I think, with COVID, I wouldn't fault people for wanting to get their flu shot right away, because we don't know exactly what's going to happen. And last year, I went to Australia in October, so I got my flu shot early because I knew I was going to a place where it was endemic earlier in the year. And so I think if you're traveling also, that's also something that may affect your timing. But definitely look for when the season is really hitting, and go at least a month before that, I would say.
Are there more side effects from the super flu vaccine for elders this year?
I have not seen the response yet from that. It's just starting up here in Rochester, so I can't tell you. Most of the side effects I've seen from almost every flu vaccine, I've been taking them since, well, med school back in the Stone Age, back when, they were still writing on stone tablets. And the only one we saw that actually caused what I consider to be serious side effects was one year, the 76 swine flu vaccine, which seemed to be connected with a rare number of people getting Guillain-Barré syndrome. But all the rest, they can cause flu-like syndrome for a day or so. They can cause pain, swelling at the injection site. They can make you feel lousy for a day. That is all better than influenza as far as I'm concerned, and I've never stopped getting it myself.
So this next question, I think, could be a webinar all on its own, but it says, please review your concern with dementia clients taking antipsychotic meds.
Yep. Well, first of all, antipsychotic meds, if you review the literature critically, and I've written a couple of books about that, show very little benefit and a lot of harm. They have been proven to increase the risk of death, proven to increase the risk of the rate of cognitive decline, proven to increase the risk of falls, movement disorders, a million other things, pneumonia, strokes, and their benefit is minimal at best for the vast majority of people. Sometimes when I get exasperated, I say, why don't we give them Tylenol? And somebody says, well, because Tylenol doesn't work. And I say, well, antipsychotics don't either. Why are you giving those? Because they really don't. The medical evidence is not there. But particularly, some people will say, well, they're really anxious and they have some anti-anxiety, or they're paranoid and they have some anti-paranoia. You know, we can argue and debate those things. But when you're using them to stop a person from walking, I believe that is never indicated. Because number one, they won't. All they'll do is make the person get up groggy and fall. There is no drug that stops people from moving. And I just don't think, that's why I don't like the term chemical restraint, because I don't think there are any times in long-term care when a drug should be used as a restraint to prevent freedom of movement. So if that's what you're using it for, I don't see any rationale for that.
So I'm gonna read this one. It says, you mentioned continuing to have safe visiting even in an extensive outbreak, if an extensive outbreak takes place. Would you be concerned about the visitors getting sick and then carrying their exposure to the community?
Oh, absolutely,
Especially,
absolutely. And I think, once again, there has to be nuance in that. Mercy Health has done really well. But once again, you're gonna have to go up and down with this. If you have an outbreak in your greenhouse home, God forbid, that may be a time when you got to shut down visitation for a short period of time. Okay, I'm not saying that this is absolute all the time for everybody. You've got to come and go with what's happening. So if there's a sign that there's something going on locally, you may have to change your policy for a short period of time. And you know, is it 14 days? Is it 28 days? I think 28 is excessive. But I think that just because we have coronavirus, just because it's in the community, we don't automatic with a broad brush say everybody's got to do this, because I think Greenhouse has once again shown with the rate of infection, you know, across the country, the rate of death from COVID is 25 times as high as it's been in greenhouse homes. So there are ways to do it safely. And I think that when we start thinking about individual situations and just individualizing each situation, we can come up with some good solutions. And we'll be interested to hear what Jen and Bob say about what they've been challenged with at St. John's and how they've responded.
so can you elaborate on what safe visitation means?
Safe visitation means at least question screening, if not a COVID test, at least temperature check, screening about exposures and about symptoms, and using all appropriate protective equipment for the type of engagement that's going to happen. So if it's sitting across the room from somebody, it might be a mask or a face shield. If it is anything that requires being closer, it might be gowns and gloves. It depends on the person. And once again, I would use the science. What causes risk of infection, what doesn't, because different activities carry different risks. And I think the same as we do with professional staff, we can do with visitors too.
There's a couple questions on testing. So one is, how sustainable is the idea of testing all residents and staff regularly, humanely and financially? So any thoughts on that?
Well, I think once again, we have to determine if routine testing is going to benefit long-term care and society. The science is slowly coming forward on that. I just read something brand new that came out that showed that approximately 40% of cases in the US are asymptomatic. That to me is a strong rationale for more widespread testing, whether people engage with long-term care or even beyond that. If we really want to do things like contract tracing and following the pandemic, we might need to do more widespread testing. So I think the theory supports it. The problem is that we still, as a nation, have not managed to get enough reagent. We have not managed to get enough protective equipment to actually make it happen however we decide it should happen. And until we get on the ball, and you know, all these businesses have closed, factories have closed. Why weren't they retooled to make protective equipment, to make hand sanitizer, to make coronavirus reagent? Why didn't we start doing this months ago? Why are we talking about this with the flu season coming on after 6 months of a pandemic? To me, this is a huge missed opportunity, which even if we talk about these things, is kind of a moot point if we haven't got the stuff. I can tell you that I have a family member who works in acute care in Rochester, has been working in an emergency room for 6 months and has yet to have a COVID test. They are withholding people who are not sick because they don't have enough reagent to just routinely test people, even though she is putting herself at risk every week. That is the reality, is that we are undersupplied. And until we come up with a solution to that, I think it's a great point, but it's still somewhat of a moot point.
Last one. Is there any data available about the prevalence of false positive and false negative COVID tests? Can you explain the scoring system used in COVID testing that determines detected or not detected?
Yeah, I'm not an expert on that, but I have been reading articles recently suggesting that at least one of the testing reagents has been having increased false positives. And we know that these are not 100%. The idea of a screening tool is really to rule out infection. So false positives aren't as important as false negatives, because we don't want to let people through a screening test that are sick. So, you know, that gets back to my medical statistics classes, but screening tests should have a very high, a very good capture of people. And if they have some false positives, that's not as bad as having false negatives. So there are going to be some, because you're better off excluding people who are not infected than you are letting people in who are. But I'm not the expert on that. And I think we're just finding out now that we're getting more widespread testing, just how good these tests are. And we have a ways to go with that. And of course, there's the rapid tests and the slower ones. The rapid tests may have a higher false positive, false negative rate because of the way they turn things around quickly. Maybe Bob knows more about that than I do, and I would defer to him on that question, I think.
All right, I'm going to turn it back over to Susan.
Thanks, everybody.
Yeah. And to follow up on that, just for whoever asked the question and anybody else who would have interest in testing, our next session on October 7 is really going to dive very deeply, specifically into testing. And we have invited a geriatrician with an epidemiology background who is going to really unpack all things testing. So you'll want to make sure that you sign up for that session, which will be on October 7th.
Dr. Jonathan Evans, he's a former president of AMDA and a good friend of mine, and he's really brilliant. And even though I'm on that talk, I'm just going to sit back and let him talk, because he will give a lot of great information about those things that I haven't been able to keep up with.
Yeah, so stay tuned for that. But I want to get to our case presentation today and invite Jen DeSalvo and Bob Wesley up to share their screen and go through their slides. So if you've got questions as they're presenting, please put them in the chat box.
Hello, everyone.
Hello.
Okay. So we're working. This is definitely a fluid process. It is changing almost weekly based on guidance from Department of Health and what we have learned over the last 6 months dealing with COVID-19 and what we can do. So a little bit about our facility, and we have Penfield Greenhouse Homes. We have 2 homes, 10 elders each. We opened almost 10 years ago, and we currently have not had, knock on wood, any positive elders test positive for COVID-19. We also have the 150 Highland Avenue building, which the current census is roughly around 300, Bob?
Yeah, 320 today.
And they're renovating from the traditional home into neighborhood style and really taking on those core values of the greenhouse. And then we also have St. John's Meadows, which is independent and assisted living, and then the Brickstone as well. So we really are a continuum of services for the geriatric population. So these are kind of our stats. We are located in New York. We are not in New York City where the biggest amount of deaths and rates of COVID-19 were happening. We had 5,839 confirmed cases, 787 deaths in Monroe County. And currently I've been watching, Bob, you've been watching, we've been having less than 1% of our population test positive.
That's correct.
So I can talk a little bit about how we are doing the COVID staff testing every week at the greenhouses. We're a little smaller, so we have 45 employees compared to the 1,000 employees that are at the main campus. We have 100% compliance. We have 2 testers. That's Polly, my nurse leader, and myself. And we're here on all 3 shifts. We've even had to come in on weekends to do the testing as well. When somebody asked about the financial and humanity of it, so the financial burden is huge for us because we did not budget for this testing to be completed. And we're averaging anywhere between 45 to 50 tests a week in our small building. And then Bob, you can talk about how you guys are doing it at the main campus.
Yeah, same thing. We have a dedicated staff. They're swabbing all the employees. Because New York State Department of Health requires us to report on a Wednesday, we use our week testing numbers from that Wednesday to Tuesday to keep it with numbers. As well, we've got testers on all 3 shifts in the weekends. We also utilize our supervisors on the off shift to screen somebody. And then it's basically a manual. We go down through the line and see who hasn't been tested. And we usually spend like Thursdays and Fridays capturing those individuals. And if they haven't been tested, going to them and make sure they get tested. And I think, yeah, we just hit the $1 million mark on testing. So that's how much it's cost us to test every employee each week for the last 6 weeks or so.
So moving into flu season, we're going to include testing and offering the flu vaccine as well. So when staff stop in to get their swab, I will also be standing by with a flu vaccine and reminding them that they need their flu vaccine. Our staff can only opt out if they have a medical note. They cannot just say, I'm not going to take the flu vaccine this year. We are also I'm doing some additional education regarding the increased importance of the flu vaccine with the COVID-19 pandemic. I just sat in on a webinar from the Department of Health today that said, if you don't get vaccinated, and you're more than likely to get both influenza A or B and also have COVID-19 on top of it. And so the 2 together could linger and also cause death and mortality. So that's really the point that I'm going to drive home to the staff, is that this year of all years, it's just as important. We've done a lot of education for staff on COVID-19, a lot of competencies, watching people wash their hands. The funny part about washing the hands is, I'll pick on my administrator, Chris. He came by to do his competency because I said, you have to be competencied in hand washing because you now can feed elders. And he did the competency with me and 2 staff members standing around, and he actually took and turned the faucet off without a dry paper towel. And the staff actually called him out on it and said that he didn't do it correctly. And so they're now doing that on a regular basis after doing those competencies. Bob, you can talk a little bit about how you guys are doing that, the education for COVID-19 as well.
Yeah, same thing. I've put a PowerPoint presentation together that each of our clinical coordinators are taking up to their staff on the floors, along with a video that is now incorporated into our orientation process. And the same thing as you, Jen. We're when people come in and get screened, probably starting in a couple of weeks, we're going to be offering staff flu shots. So as you get screened, you're going to be getting your flu shot right along with it, so we can track compliance that way.
And so we do daily staff screenings of questions, but we also do them for anybody who comes into our building. So visitors, Al had to be screened when he came and got his mom here. But it's really asking those vital questions. Do you not feel well? Do you have a fever? Are you nauseous? And asking them. Our employees screen themselves at the employee entrance, and then I audit them almost every day that I'm here. I'm looking at them to make sure. We posted a sign above our time clocks that actually said, if you answer yes or have a fever, you need to call me no matter what time of day or night it is, so that we can talk this through and figure out, do we need to send you home? Do we need to get you tested for COVID-19? Bob, you can talk about what they did at the main campus.
Yeah, so we're screening about 400 staff members a day. So we've taken one of our entrances. There's only one entrance into the building for staff members. So they have to come in. We have 3 screeners. Again, they go through the screening process, ask the questions, looking for symptoms, take their temperature. Have they traveled to any of the restricted states, any of that stuff. And then they sign an attestation that says, I do not have any of these symptoms at this time, before they go up onto the floor. If any time that they say they have, a cough or one of the symptoms, then they call either myself or Rick Rosati, our employee health nurse, and we will go screen them. If it's the off shifts, then it's one of the off shift supervisors will actually come down and screen them, give them a second, more thorough screening, and then send them home with a follow-up COVID test, or let them up on the floor depending on their findings.
In our facility, we've not had anybody test positive for COVID-19. We do have a plan in place should we have an elder test positive, because guess what? Someday it may happen. We've just been fortunate. I think what helps us is we have a small environment. So we have 10 elders on each floor, on each house. It's not a large environment. We have all private rooms with private bathrooms. The positive is the elder will remain in that room and placed on droplet precautions. We'll use disposable dishes, disposable utensils. We have dedicated staff here at the greenhouses that have been trained and competencied and tested to fit the N95 mask. And so that staff will be the staff that will be in caring for the COVID positive person. We've talked with the staff that has participated and said, okay, if we have somebody who tests positive, we're going to need to 24 hours a day figure out how we're going to provide care for this person with a limited number of staff. And we're able to do that here at the greenhouses. I know that's not feasible at the main campus. And Bob, you can kind of talk what they do at the main campus when somebody tests positive.
Yeah, so early on back in February, as we kind of anticipated COVID coming, we actually had about 10 rooms on one of our resident for 2 floors that could actually be closed off. It had a locking door on one end of it and then a double door. So we could put our positive elders back there. This gave us a way to immediately separate and take a positive resident off the floor to lessen the spread. Anything in that area would be full PPE, etc. And we actually, we did a kind of a little enhanced pay for the people working in that area with positive residents because they had to wear full PPE all the time. That's kind of how we justified it. But it actually worked out very well because we had people that they didn't back down. They stepped up and cared for all our residents who became positive.
I think, you know, some of the things that we learned in the beginning, and one of the things that St. John's has always really done well is its communication is the key to the success of any, whatever you're doing, not only to the families and the elders, but also to the staff. We do have a daily email that goes out to families, letting them know how many positive cases we have every day, how many negative tests we get back. Families are, you know, they do look at those things, and they're watching them, and they're watching to see. Right now we have a rule in place where 14 days of no positive elders or staff, then we can resume visitations. What that visitation will look like is we still haven't gotten clear guidance on that. But families are watching that email to see, are they, you know, is there more positives? Who's the positive? And, you know, where are we at the mark? Like Al said, a majority of our staff that has tested positive, they've been asymptomatic. So they've been fine in the building one day, been tested, and then 3 days later, we've gotten a positive result for them. And then they've been out of work for 14 days, and they need 2 negative tests in order to return to us. And we've been fortunate, our elders have not tested positive. We just did a round of testing everybody for the last 2 weeks because we did have a positive staff member. And I think the reason why we have not had an elder show up positive, even though we've had 5 staff members test positive for COVID-19, is because our staff is wearing that PPE and they're doing what they need to do. We're screening our elders daily for symptoms of COVID-19, as well as doing vital signs on all our elders. And anytime anyone's symptomatic, we notify medical immediately, and we immediately initiate the COVID-19 test, order a COVID-19 test. We immediately place the person on droplet precautions until that test comes back either negative or positive. So it sometimes takes up to 24 hours for a test result to come back, but we're able to immediately, because they're in a private room, shut the door, put them on precautions, and immediately start that precaution before we actually get the positive test result in hand. And Bob, what are you guys doing at the main campus for that when you guys suspect?
Same thing. We will take the person out if they're in a semi-private room. We don't have very many semi-private rooms left, but we immediately, if they're symptomatic, we'll put them in a private room, test them, immediately put them on full PPE, droplet contact precautions, and until we get a positive result. In that case, if they are positive, we will put them on, you know, one of our COVID positive floor at that time.
So I know elders and flu shots is a hot topic right now. We're aiming for October 1st to complete all our vaccines at the greenhouse homes. We're actually, Polly and I will be going around and giving everybody their flu shot on October 1st. Again, we have 20 elders, so it's very easy for us to get them done in one day. We sent out a mass email as well as a letter that's mailed out to all the families. And they have the option to notify us if they want to opt out of the flu vaccine. When that happens, when I have a family that opts out, or even an elder that opts out, I, as the infection preventionist, will follow up with them and talk with them about, why are you opting out? What's your concern? How can I alleviate your fears? And then I also explain that, you know, what happens if you don't get the flu shot, you may get the flu. And a lot of times what I get from families and elders is, well, the last time I had it, it made me sick. And, you know, 9 times out of 10, they were probably already sick before they got the flu shot, or they're just getting a mild side effect to it. But I know, Bob, you said you and the nurse leaders are going around to do them.
Correct. I will go floor by floor, usually set it up just like a flu clinic, use like an empty conference room, or what I can, have our nurse leaders bring each resident to me, and then screen them, go through the questions, and then provide the flu vaccine. this is one of the ways I can usually get 100% compliance, because I just make sure I do it myself. And, you know, any family members that opt out, again, I do the same thing. I can reach out to them and our medical director and really talk to them about, you know, the importance of the flu vaccine, especially with COVID coming up this year.
So one of the biggest struggles that we noticed was when they cut off visitations to us 6 months ago. We got a lovely email at 5 o'clock on a Friday evening that said, you have to not have any visitors as of today, starting effective immediately. And so we quickly thought, how can we make sure that families can still have touch and communication with their loved ones? Talking on the phone is tough. You can't see the person. So we immediately went out and bought iPads, one for each house, and we set up Skype as well as FaceTime on the iPads. We're also one level, so we don't have a second floor. So we could do window visits where the person could come to the window with the window shut and sit outside. We have lovely weather in the summertime here in Rochester. They could sit outside, they could be on the phone, and the elder could be on the phone, and they could actually see their loved one through the window. So we were able to do that for help with communication and help with that loneliness and that isolation that the elders were going to feel. We knew that going into this, that was going to be tough, not only for our elders, but for our families, because they were used to the open door policy here at the greenhouse. So they had key fobs, they could come and go as they wanted. And we knew that was going to be a struggle when this ruling came into play. We were granted palliative visits, which we are able to determine on an individual basis. And we've been able to, we use those mostly for our hospice patients here at the greenhouses. When the families come to visit though, they, like Al said, they have to wear the entire PPE. So they have to wear the mask, they have to wear the face shield, they have to wear the gown, they have to stay in the elders' room. They can't be out socializing with the other elders. And so we are using that for a lot of our hospice patients or residents, as well as using it for some other, we have currently somebody with some mental health issues that we're utilizing it for because it was not going well when we didn't allow the visits for her mental health. And Bob, I know you guys are doing them as well.
Correct. We're same thing, we're using iPads, do the video chats. Our window chats are going very well, as well as palliative and compassionate care visits. We do have a few residents with some language barriers and stuff that kind of their family would come and feed them every day. And when, like Dr. Power said, you got to kind of look at their surroundings and stuff. We've actually allowed those family members to come in and deem it medically necessary because they're feeding their loved one and they're actually sustaining and doing well because their family members in feeding them. So we use all the above. Yep.
That's it from us. Any questions?
Wow, thank you, Jen and Rob. That was Bob, that was fabulous. So Al, I'm going to start with you and then Eric, and then we'll go to what was in the chat.
I thought it was a great presentation. I think I've spoken enough, so I'm going to cede my time to everybody else. Thanks.
All right.
Thanks to Jen
Eric?
and Bob for a great presentation.
Eric, anything from you?
Actually, pretty much the same what we're doing at the Jewish Home Family, you know, the testing, you know, constant education is the key as well with infection prevention. Not only the testing, I know testing is very important, but education, infection prevention, the proper wearing of PPEs, you know, that makes a big that makes a big difference. The only just a comment about influenza vaccinations. You know, it's so important to have flu shots actually within this period. What we've been seeing right now is we're slowly seeing, because the season is changing, elders and staff members are getting sick. And with this, you know, there's a hypervigilance. So what happens is if the person is sick, automatic, we give them days off right away, even though a simple cough or cold, because everybody has this on stage of high alert. So I can see it, I can picture it, that the flu shots are so important because of, if there's a lot of positivity, there's a lot of wasted resources that's going to happen. So again, it's very important to take the flu vaccine in this season.
Yeah, thank you for re-emphasizing that, Eric. I think that's a good point. Marla, how about let's go to you to see what came up in the chat.
All right, there's a few of them. So one, just a clarification, do you test 100% of staff weekly, or do you do 25% of staff once a week to get to 100% monthly?
So our mandate is we have to test every staff member, whether they work full-time or part-time, once a week in our facilities.
And you are mandating it except for with a note for your team members, correct?
That's only the flu shot.
Okay. Have you seen any severe itching or hives from the flu vaccine?
We haven't given any flu vaccines as of yet for this year. The only time in my practice I've ever seen severe itching is when somebody's been allergic to one of the preservatives.
Okay. Are you able to do, this is on testing now, are you able to do point of care testing on site, or are you sending out all of the labs?
We're sending it all out.
We're sending them all out. New York State has divided up each area in New York State, each region, to one of the 7 different labs. So like Western New York, we send all our testing out to Quest Labs.
Quest Labs, okay. That was the next question, what lab? Are there any other surveillance precautions you'd like to see implemented?
No, I think the screening tools are the best ones. I mean, the stopping people before they even come in is key, and have them follow up with employee health. But we're seeing the asymptomatic positive come in as we've tested all our staff members. So it's not impossible.
Right, to piggyback off that, I mean, our test results turnaround time is sometimes up to 7 days. So potentially that employee could be working while they're asymptomatic for those 7 days.
It was mentioned a couple different times by a couple different people, the importance of education. And so one thing in the chat box is, Jen, would you be willing to share your flu and COVID-19 education materials?
Absolutely, yeah.
All right. Susan, I think it's of the hour, so I'm going to turn it back to you.
Yeah, thank you, Jen. Thank you, Bob. That was fantastic and really appreciated the different approaches, but yet similarly and aligned. So thank you very much. I'm going to ask Janet to go to some poll questions. So if you could just hang for a couple more minutes, we'll zip through some questions. These are helpful to understand kind of what you're doing and how we plan future sessions. So social isolation, and certainly Dr. Power talked about it. I want you to, this is multiple choice, to take a look at all the strategies you are currently implementing to ease social isolation of elders. We know social isolation is of incredible concern right now, especially at a time of a pandemic. So what are you doing? So take a little bit of time to go look at all of these. This is multiple choice. Indoor visits in designated spaces, indoor visits in resident rooms, outdoor visits, courtyards, patios, parking lots, physical barriers using the plexiglass and other creative ways of doing it. Limit the amount of time per visit, number of visitors. So a few more of you, if you would want to just indicate what you're doing. Give just another few seconds. All right, Janet, you can stop the poll. Well, it looks like 94% of you are certainly doing the outdoor visits, not surprising there. Many of you are using the physical barriers, limit the amount of time per visit. 65% say compassionate care towards the end of life, which would make a lot of sense. All right, let's go to the next one. Thank you for your response. This is about your occupancy, and people have talked about occupancy. This again is multiple choice. So we're really wanting you to talk about how COVID has impacted or not your occupancy rate. So your occupancy rates have declined because of COVID. Your occupancy rate has increased since COVID. You haven't experienced a change. You were occupancy challenged before COVID hit. We were on the decline due to COVID, but are increasing occupancy now. And then other, and if other, maybe it is you, this is not necessarily applicable to who you are as an attendee. So I would love to hear what your thoughts are. And again, it's multiple choice. Okay, Janet, you can stop the poll. And it's not surprising to me. You certainly bear witness to what I read in the papers. So 59% of you say that your occupancy rate has declined. Only 6% said it had increased, 12% you haven't experienced a change, 35% said you were on a decline, but you're seeing some improvement. All right, one more question. And the next is about your workforce. So similarly, how has COVID really impacted your workforce staffing? And this is multiple choice once again. So you've had challenges with having enough staff pre-COVID. You are challenged to maintain adequate due to COVID. You're trying to hire new staff during COVID has been especially challenging. We do not have staffing challenges. We have increased wages to meet the staffing challenges. We have increased staffing ratios to better meet the needs of residents because of some of the COVID-related challenges. So again, this is multiple choice. If you would just indicate your answers. And of course, there is an other box as well. Just a few more seconds. Thank you so much for responding to these polls. It really is helpful as we're doing our planning. All right, Janet, you can stop the poll. Ah, we've got a tie. We are challenged to maintain adequate staff due to COVID. Hiring new staff has been especially challenging. 27% said you have increased wages to meet the need. 20% said you've increased staffing ratios to meet the needs that COVID has brought on. And almost a third of you said you had challenges pre-COVID. Thank you so much. Janet, you can close the polls. Thank you everyone for attending today. Thank you so much for the work that you're doing every day. And I can tell you that these are tough times, and we're heading into the fall. And we must be vigilant as we continue and carry on. But we're better together, and we're better when we're able to share our collective wisdom. So remember, October 7 is the next COVID Echo, and we will be talking about all things testing. So we look forward to seeing you then. So thanks everybody for joining us today. Take care. Have a good rest of your week. Be safe. Be well.